I suppose it's a little bit of an interesting kind of preparation for the talk, just because I'm very much used to talking to neonatologists. At a push, I'll talk to pediatricians, but a wider audience is something different. So occasionally to an obstetrician, yes. So I suppose I'm going to go over this very much folks from a baby's perspective. And really what I want to talk about is the very definitive proven benefits of cesarean section for the newborn, some of the proven risks. Yes, I will try. Okay, so is there? Do you want to get that? Does it work? Sure.
That better?
Yeah. Okay, so I will use this because I've never had a talk where somebody hasn't asked me to speak up. So, so I suppose I want to go over some of the benefits, the risks, and then some of the query associations. I'm going to skip over this since Mike and Richard did such a good overview of the history. But I suppose a good place to start, just as a segue, is the increasing rate of cesarean sections, and it's globally. There is obviously variation. These are the reported incidents from what I can find from national registries for South Africa, Scotland, and Republic of Ireland as recently as I could. But C-sections are going up. And from a baby's perspective, the question is that a good thing or a bad thing? Now, Mike referred to this paper a little bit earlier. This is the Molina paper that looked at neonatal rather than perinatal mortality. And I suppose it's an interesting one just because this procedure is at the interface between specialties. So while a lot of yourselves, very appropriately, who need to make a decision when to section, are going to be very focused on all of the perinatal mortality, from somebody who then is looking after who do I need to resuscitate, my focus is going to be, not that I would dismiss stillbirths, obviously, but it's going to be really wanting to know the raw data on the neonatal. What's the mortality for those who are actually alive at the start of pregnancy? So it is very much a pediatric paper. But what Molina showed was across 191 countries that if your C-section rate is in the 10 to 19%, so roughly 20% it was up to, that there was actually an improved survival relative to those countries with a lower C-section rate. This is large epidemiological data. It's really just association as opposed to cause and effect, but there was a reduction in mortality up to about a 20% C-section rate, and the mortality didn't reduce further than that. So that's great. It's not cause and effect, but I think we can all be quite clear the cause and effect is about neonatal encephalopathy. So for some of you who aren't medics in the room, neonatal encephalopathy is really when a baby is deprived of oxygen somewhere before birth, during the pregnant or labor, or after in the immediate postpartum period. So neonatal encephalopathy, the rates of it, and there is such good data, is dramatically reduced by cesarean section. And this is not surprising. If a child or a fetus, I should say, is in distress during the labor, an emergency cesarean, and I apologize, I will probably flip back and forth between elective, emergency, planned, unplanned, second stage, with labor, without labor. There's so much different nomenclature around it, so apologies if I change my terminology at times, but it's more to say that as the fetus is in distress, an emergency cesarean absolutely can reduce the risk of neonatal encephalopathy. This is Norwegian data, and this is basically large cohort data, or not cohort, national data registry, demonstrating that between municipalities with a less than 10% versus a 20% C-section rate, the occurrence of neonatal encephalopathy and cerebral palsy is significantly lower. And it's really in that 15 to 20% range, in this Norwegian data at least, is where the maximum benefit was, and higher than that, there wasn't the same, or there was no added benefit. Now, That's not saying that there was harm in any regard, but it's more to say that about 15 to 20% of babies or fetuses, an emergency cesarean was reducing the risk of neonatal encephalopathy, and that makes sense. It's not that the higher is causing harm, it's just that you have saturated the benefit in terms of the emergency procedure. And there's lots of other data that supports this. This is a large single center study. It was from, I can't remember where, but it was again like over 20 years, again, a 21% C-section rate, and the neonatal encephalopathy incidence fell very dramatically. I mean, for any incidence that we would all be wishful of 0.2 per thousand, but still demonstrating a significant reduction. Nadia Badawi's seminal work that came out of the Western Australia study. This is more of kind of, as opposed to a large data sets, getting down to individual cohort studies, so you can actually get a little bit more about cause and effect. And what Nadia showed was, I suppose, the difference between different modes of delivery and neonatal encephalopathy rates. Now, what she showed is that elective cesareans have a very low encephalopathy rate. That is obviously exactly what you would expect. These should be fetuses who are in no distress, a planned cesarean, and they're delivered, and they have never had to go through the difficulties of labor. They have a very low neonatal encephalopathy rate. Their emergency cesareans was a higher encephalopathy rate than spontaneous vaginal deliveries. Again, that's not surprising because the majority of spontaneous vaginal deliveries are not in distress. So that you're comparing non-distress normal deliveries with fetuses in distress. So it's not saying that an emergency C-section is a risk. It's more just trying to tease out and showing that elective C-section is actually further protective against neonatal encephalopathy. And there's lots of other, like the work from the UK, Martin Biarge, and that's part of Francis Cowan and Rutherford's group, showed very similar, that there was absolutely no no cases of neonatal encephalopathy from that was associated with elective cesarean. That was the Hammersmith 405 cases over 25 years. There's very good data out there about the reduction in acidosis as well. So it's like there is reduced perinatal acidosis, reduced encephalopathy. So elective cesareans are protective. It's not just neonatal encephalopathy. I think in terms of weighting your outcome, neonatal encephalopathy has to be paramount, but lots of other types of birth trauma that can occur, as we know, brachial plexus injuries, facial palsies, fractures. And what the data repeatedly shows is an elective cesarean has a lower risk of all of these in terms of composite outcomes and individual spontaneous vaginal delivery. And again, these are large meta-analysis, large population data sets, because the incidents themselves are relatively low. So you need huge numbers to demonstrate significance, but by avoiding labor, you do avoid some of these risks. And it's really obvious in some ways, but there is very strong benefit, or proven benefit, I should say. So I haven't gone into all of them, but just to give you a quick synopsis, these are the types of benefits from Caesarean section. So there's reduced neonatal encephalopathy, depending on your C-section rate. There is definitely reduced encephalopathy with elective C-sections. There's reduced birth trauma, brachial plexus. There's reduced death, which again leads back to the encephalopathy. HIV vertical transmission haven't gone through, but obviously there's a significant reduction, and it does depend on viral load, but there is a reduction. There's a reduction if there's active genital herpes. The hyperbilirubinemia is, I think, not real, but there is evidence to show a reduction, but I think that's again due to reduced trauma, reduced hematomas, and things like that. So it's a byproduct of the other, let's put it that way. So I suppose, particularly as a neonatologist speaking to obstetricians, I did want to come out here on my high horse saying all of the woes of C-section without starting with the benefits. And where the benefits are clearest is obviously in breech presentation. So we know across all gestations, there is really strong evidence that for breech presentation, newborns do better if there is a cesarean section. That is not trying to dismiss the, I suppose, choice for an individual, but the risks to the baby do go higher for a breech. I think the other area that in a neonatologist perspective is really interesting at the moment is about preterm babies. And our preterm mortality globally is improving, and particularly in high-income countries, consistently. This data is now 10 years out of date. This is from the NRN in the US. And Barbara Stoll basically showed that over that period of 20 years, mortality was reduced for 23 weeks, 24 weeks, 25 weeks, and that C-section rates are going up all the time over this period. This is a much more recent paper. It's a review article from in AJOG that just came out, but showing the actual preterm C-section rates. And you can see that a lot of it's driven by non-Catholic presentations, but there is a sizable minority, even at 22 to 24 weeks, that are having cesarean sections. And one of the real hot topics in neonatology, I suppose, and there's a lot of chatter about cesarean sections in this context, is 22 weeks. I am in no way advocating for a C-section at 22 weeks, but with an increasing survival at 22 weeks, if you look at the academic sites that are leading this, and Japan as a nation as opposed to an academic site, there's a huge number that are performing C-sections without evidence of benefit. But if you look at, say, the primary drivers, 40-something% in Japan, I believe, are a C-section. And they use that as one of their references for their benefit survival. Obviously, it is a slightly false statistic, because if you do a C-section, you're absolutely going to go for active management, whereas one of the major mortalities is non-active management. So it decides, like, it's a bit of a fait accompli. There is absolutely no evidence for C-section at 22 weeks improving newborn survival, so I really wouldn't be advocating for that. But it's more to say, in my side of the literature, it's what's more hot topic now at the moment, and there's a lot more discussion about it without any evidence base. And I think that's where we come down to, in terms of the evidence base, there's really good evidence for C-section preterm infants if they're breech. That reduces deaths, it reduces IVH. There's really not good evidence if they're vertex in terms of method of delivery. And so overall, as a neonatologist, I would strongly advocate, if the family's decision is for active resuscitation, that in a breech there should be consideration for a C-section. But in everything else, you shouldn't necessarily be advocating for that. And it needs to be a discussion with the family about the impact on the woman herself, the chances for her future fertility. And I really don't think that there is any good evidence to support it. So at 22 to 24 weeks, 27, 25, 27 weeks, there is, there is evidence of benefit if they're breech, but beyond that, no. Okay, so I'm doing okay, I think, for time. I started a bit late. So the actual risks now. This is, again, it's not rocket science, they're obvious things. We know really well that an elective C-section has a higher chance of requiring a NICU admission. And this is largely gestation dependent. So if you have an elective C-section at 37 weeks versus 38 versus 39 to 40, there's a big difference. It goes from about 17-point-something% at 37 weeks admission down to about 4.8% at 39 weeks. The chances of maternal infant separation, about 11% higher. I think it's an odds ratio of 1.11 with elective C-section. And again, that's obviously driven by NICU admission. Chance of respiratory distress, they're about twofold higher. The chance of neonatal hypoglycemia, breastfeeding establishment, all of these things are well proven to be associated negatively with elective cesarean sections. Now, much of this is gestation dependent, so that in this table, it's a little bit of unfortunate that they put the proportion so that the dark blue is the proportion of deliveries at each gestational age week, and the light blue is the primary outcome, and the primary outcome was a composite of all of these negatives. So RDS, TTN, admission, sepsis, but that was unconfirmed sepsis, so not the blood culture, CPR, etc., etc. So the idea is that there is a U-shaped curve, and this is repeatedly shown that 37, 38 weeks have higher risk, 41, 42, 39 to 40 is the sweet spot, and that as opposed to saying an elective cesarean is the association, you have to try and tease out the procedure versus the time at when the procedure is performed. And this is obviously a horrible slide, so don't try and read it, but it's more to say that all of those individual composite outcomes, they're all associated with the age that the child is delivered at. So RDS decreases from like what is a relatively low percentage, I appreciate, in terms of absolute numbers, but 3.7 to 0.9 and goes back up. TTN goes down and back up. Admission, hypoglycemia, whichever one you want to look at, it's all of the individual components of the composite actually are significant in following that same kind of trend. So that it's really about the age, gestational age, that the procedure is performed rather than the procedure itself. Except maybe for RDS, but aside from that. And it's not just those morbidities, it's also mortality. So this is based on US live birth data, so it's about 2.5 million births. This is from early 2000s, and basically what they looked at was, so again, this is where terminology keeps changing, but indicated versus non-indicated cesareans versus spontaneous delivery. Given that this is population-wide data, we can infer that indicated is likely emergency and non-indicated elective, but you really like assume maybe as opposed to even infer. You can't really get more detail than that. But what it's trying to show is that even then there is a curve, but for elective cesareans, which is the kind of line with the white, like the white dots, it's really only at the 37 weeks that it separates away from the spontaneous delivery. An emergency cesarean or an indicated cesarean is always going to be a higher risk because there's a reason that that's indicated. But the elective is the ones that are kind of more focused on. Morbidities are the same that I previously described: admission, ventilation, seizures, and they're higher for the indicated than spontaneous at all time points. But it is in that kind of 39 through 40 weeks, that's when everything from an elective cesarean and spontaneous vaginal delivery comes much more closely in line. And that's really why ACOG is recommending 39 weeks for elective cesareans. This isn't actually cesarean data, I should put that in there, but it's more to say it's not just short term. This is 7-year outcome data for early term, so 37 to 38 plus 6 weeks versus term versus late term. And you have bronchiolitis on your left and pneumonia on the right, and hospital admissions for each of them, I should say. So it's really to try and show you that early term is not term, and this is independent of any method of delivery. These children have increased risks that go on for years, so that up to 7 years of age, there is a significantly higher hospitalization for respiratory symptoms. even in a 38-weeker versus a 39-weeker. And if you want to take it further, this is a separate large population study. This one's, I think, from Israel. And this is up to 20. And it's the same thing. Higher rates of hospitalization for pneumonia, higher rates of asthma. And I would stress this is not based on method of delivery. It's more trying to say the time at which the child is born really does matter. So that, you know, an elective cesarean at 37 weeks, rather than saying the cesarean is causing it, it's always going to be confounded by the actual gestational age, which has significant risks still. This is another kind of just demonstration of some of the concerns and risks. So this is a Scottish study, isn't it? Yeah. Again, Scottish national cohort data with follow-up and showing that there's higher rates of asthma, IBD, and obesity for children following elective cesarean sections. Now, they did not go into the age at which they're born. So I suppose it's also trying to see or think through, is there other reasons that actual cesarean section could be associated with some of these risks? Now, I would say, let me just, oh yeah, sorry, I got ahead of myself. The Black study actually didn't show, it was, I don't think there's any such thing as a trend. If you want to be strict about statistics, it showed no significant difference. But the meta-analysis that followed, which included the Black study, did show a significant difference across all of them. And it's because the absolute risk is relatively low. So you need massive numbers to see it. And you can see these numbers are like 200 or so thousand children, 320,000. So it's large numbers, the individual child risk is low, but there are actual associations that are long-term. And much of the reason it's considered in the pediatric literature around this is actually to do with difference in the microbiome. I'm always so. So it's really, there's no data to prove cause and effect, but there is data to say that the child's microbiome is different if they're a C-section versus a vaginal delivery. And this is trying to show that, I suppose, a C-section, top left, they have like skin bugs in their microbiome of the gut, whereas they don't. On the right is kind of the typical bugs that you see, Bacteroides and things like this. And that change lasts for up to 2 years. This will be really quick, I promise. My own interest is really neurodevelopment, and I suppose there is, again, large meta-analysis data saying that there's increased risk of ASD, ADHD with elective cesarean sections. But I do want to be careful. The data is conflicting that's out there. So one meta-analysis say that this is a separate study that large population-based says that there is no increased risk of ASD or ADHD with a second stage C-section, which should be a higher risk than elective cesareans. And then a different Swedish data registry, which again shows a increased risk of ASD, ADHD associated with elective C-sections. But the reason I put this up is that the actual difference, the actual change that they're seeing is minute. So a change in incidence from 1.6 to 2%, so 0.4%. So for the individual child, not really much a change, just population-wise. But again, this is just came out a couple years ago, and it was really showing that there weren't difference in risk for their neurodevelopment of these children if they're delivered at 39 weeks, and it's to do with all the confounders. So I am going to conclude with that to say that there are very definite real benefits to the baby, and like improved survival, and you can't trump that, I suppose, and reduce neonatal encephalopathy. There are risks, most of them are short-term, but there is some data out there, and it's increasing, about potential impact, long-term risks for asthma, obesity. It's the neurodevelopmental data. I think there's a lot of confounders in there, so really hard to tease out. And I think that one of the major risks is really to the gestational age which they're delivered. But there is risk mitigation that can be done. and I won't go into that in the interest of time. Thank you.
And that's